tree.
Is there a whiteboard? I wonder if I might write the letters.
Oh, do you want to?
Yeah, why don't you do that?
Why don't we move back and then put chairs in between?
Whiteboard?
You gotta throw some space.
Where should we put it?
Right here?
I just this morning repeated this 4 times what it is to the guy who set up the phone with me, so
Oh.
what would he write it?
You're sitting here? Yeah, this is great. Oh. If you need me to move it. Why don't you sit here? Okay. It is. That's fine. Okay. Do you need an extra? Let me get some fingers. I love your shoes.
Thank you. Well, I ordered those from the internet. It's like slippers.
We have a possibility of a Ustream video, and this topic is on palliative care. So it's really about talking about living the best life you can live, even as our disease gets worse, wherever we find ourselves. And it's about quality of life. Well, Judy will talk more about that. But it can also be kind of emotional. So does anybody object to having the camera over there?
I know that there were multiple people that said they were.
They were not. Are they here? No, what I mean is, are they on the grounds? Maybe we shouldn't do it then.
Should we go tell them?
We should then round them up.
Okay, yeah. Do you guys mind if we don't do it?
That's fine.
Because
Are there people online?
out of respect for,
Well, why don't we go
Actually, there's
ask
5
the
people.
people, and then if they don't come, then we can just go.
there's 5 people
watching
online.
us right now.
Can you just stream the audio?
Does that make
That's a good
people feel
idea.
a little bit better, maybe if it's just the audio?
Well, the people that you're asking that question to are probably not.
Right.
Let me go ask them.
Okay, sure. Sorry, let's not
That's
delay
okay.
again.
I think
This
it's
is
important.
important.
It's really important.
Stream if it's only if they only get her questions and answers, so they only hear her. Oh, no, so like keep it.
So like it's just on you?
Keep it private.
Yeah.
I mean, I don't mind.
Right.
I
don't
don't mind.
The camera could be on her. Oh, good. Well, while we're getting an answer, why don't we spend the time to introduce ourselves? And Judy Pasada came from Stanford, and she'll introduce herself thoroughly, but why don't we tell her who we are?
Right.
Sonia, do you want to start?
Sure. My name is Sonia. I'm 37. I have CF, pre-transplant, and I'm looking forward to hearing you speak.
And I'm Isabel, and I'm 40, and I'm 8.5 years post-transplant.
I'm Kelly, I'm 33. I'm treated like CF and I'm pre-transplant.
I'm Monica, I'm 34 with CF.
I'm also looking forward to your lecture today.
Brian, CF 36.
Kayla, CF 22.
Carol, nurse, no CF.
Robert, CF 23 post-transplant.
My name's Cindy, I'm 29. I don't have CF, but I have
And behind Cindy?
Anna, 31, CF 21 post-transplant.
Do you guys want to open up so you can join in?
Oh, no. No, we're fine. It's in.
Yeah, I think I might have my phone.
Because if you jump in the Here, I'm going to
Yeah, this is fine, we can do that.
There, that's better. You're not talking to the wall.
I know, I did this at RAP this morning.
You guys can see
Okay.
the camera.
Okay, Kayla, and then, Cindy, and now Devin?
I'm Devin, I'm 21, I have...
You have what?
This is exactly.
Well, it's where you like fall asleep, and then all these fairies come circling around you, and then they turn into a rainbow.
Yay!
So happy to have CF.
The right.
Perspective.
I'm Chris, I have CF, and my age, I'm 35.
I'm Kevin, I'm 17, I don't have CF, and I'm an intern.
I'm Jamie, I'm 44, and I have CF.
Danielle, 25, I have CF, and I'm about 8.5 years post-transplant as well.
So about right, 47 with CF.
So shall we get started?
Please
So
introduce
my name
yourself.
is Judy Pasalia. I'll put my name down here as well. So a big, long last name.
Excuse me, by the way, people's cell phones off for, as I remind myself.
And I am a registered nurse with a specialty area of palliative care. And I wrote it up here because it's kind of a new word for many people, palliative. And palliative actually means to cloak, to care for. It comes from a Greek word. And palliative care is it's a approach to care that is kind of growing and growing and growing. So it's really a pleasure for me to be here today and to share it with you, because I think maybe some of the principles of palliative care, or all of the principles of palliative care, will be applicable and may at some point in your journey be helpful to tap into. So palliative care is an approach to health care that is very holistic. It focuses on the patient from multiple dimensions. So I'm going to do that on the next. So this is kind of our framework. We say physical, social, psychological, and the middle is quality of life. So what our approach in palliative care is, we focus on the patient holistically. So when we say we look at their physical, we look at patients who have pain or other symptoms, and we focus on managing the symptoms to the best of our ability. We look at social factors. Do they have social commitments? Do they have children? Where do they live? Do they need equipment? Because we know that a person who has a serious illness or a chronic illness, they have social needs that are specific to them. So we look at their social. We look at psychological. How are they coping with this illness? Do they have a coping mechanism? Do they have a history of depression? Has it been addressed? Do they have a therapist? Exactly. How are they coping? Do they have a therapist in the community? Do they have a social worker? So we're looking at coping, and then we're looking spiritual. Do they have a spiritual community, faith community? What are they hoping for? What are their existential concerns? And the philosophy for palliative care is, if we have a person with a serious illness and we don't look at all of these dimensions, it's really hard to have good quality of life, right? Because if we just focus on the pain and symptom management and we don't pay attention to their coping strategies or their current social situation, we're going to miss a whole lot of stuff. So palliative care is a field that's really evolved. I have been a nurse for a very long time, since 1975 actually, and my nursing career, I told Isa that when I started, and I forgot about this till I walked in here today and sat with all of you. When I was a nurse in college, I had one interest, was to be a pediatric nurse. I just wanted to work with children. And I graduated, I went right into a four-year college, so I graduated, I was under 22. I was pretty young. And my first job was at UC San Diego in the pediatric unit. And guess what they had tons of children with?
Ah.
With CF. And I can remember their names and their little faces. I will say it was really hard for me at that point in my life, in my career. I didn't have the maturity, and I wound up moving on to another field. And here I am today in palliative care. So I came back because I was able, as we grow, we can deal with so many more things. But so palliative care in 2000, the year 2000, I had gone to graduate school and I was working with cancer patients, and I started to just identify that we had a lot of patients that we weren't doing this. We were expecting them to make decisions, to think about their care, to be part of the decision-making process. They didn't have the information. People didn't really sit with them. And at that point, I stepped back and thought something is wrong with this system. And palliative care started to emerge like in 99 and 2000. And I started to going everywhere I could to learn more about it. I found other folks I was up at California Pacific at the time in San Francisco, and found other people that shared my interest. And it's just like, it's kind of the momentum. So there's a lot of us in the 2000 really would, community-wide from all over, we'd meet like you're meeting, and we'd be in rooms, and how can we bring this to our patients? And it's happened. I mean, in 2008, it's brand new really, it became a subspecialty in medicine. So just like your pulmonologist, which you all have, I'm sure, or maybe another specialist, now there's special physicians who just do palliative medicine. And that's where in 2007 Stanford started a program, which I'll talk about in a minute. So palliative teams are always more than one discipline. Can you think about why that might be? And when I say more than one discipline, what does that mean to you?
More than just one specialty, like they cover more of the whole body, including like the mind, rather than just a specific topic.
Exactly. One person can't do all that, right? You might have the best physician in the world, but he can't do it all. So we say disciplines. We have physician, palliative care certified. We have nurses who are palliative care certified. We have social workers. Then we work with our chaplains at Stanford. We even now, as we're speaking, are weaving in a psychiatrist. Nice. Not on our team yet, but he's overlapping with us, and I think the hope is that the day will come where we'll even have that component. So it always has to be all these disciplines to address the various needs, because every person's very different, and it depends where they are in their trajectory of illness. And when I say serious or chronic illness, when we introduce ourselves to patients and family, that's always our first, we think if we can get through that, we're off and running, because it's difficult. So we'd say we're a palliative care service, we're a resource here at Stanford. Another level of resource for you is where we start. We address your pain and your symptoms, we are holistic, and we're available for emotional and social support. That's kind of where we begin, and then we'll meet a patient and their family, and we'll listen and listen and listen, and really try to assess where they're at and how we can help them the most. Does that make sense? So that's our framework, and we go back to that constantly for every single patient. At Stanford, we see a lot of cancer patients, and a lot of patients in the ICU, and patients really all over the hospital, any patient with a really serious illness or a catastrophic illness.
Can I ask a
Sure, you can ask questions the whole time. This is your talk.
My understanding of palliative care was sort of like when people had, declined further treatment and we were just kind of making them comfortable until they died. Is palliative care looked at differently in different hospitals type of thing, or is this just my misunderstanding of what palliative care is?
Tell me your name again.
Bob.
Bob, I'm so glad you said that, because that is the perception of not only patients, but every physician in the healthcare field. So how many times a week do we address that? Every day? Every new patient we see, we have to go back to that. And with physicians, we're in the out in the outpatient centers now, and I've learned that before I see a patient, even if I get a referral, I go to the workroom and introduce myself to the attending, because he kind of runs his team, and we cover that before we cover anything else, and then we can move on. So what people think is palliative care equals hospice.
Right.
Comfort care, end-of-life care for the dying patient. The big difference with palliative care and hospice is for patients who have a prognosis, 6 months or less. All measures are focused on their comfort. They're doing nothing to prolong their life, right? So that's a hospice patient. Palliative care is care that can be delivered while at any time during the trajectory of an illness. The patient does not have to have a prognosis or 6 months or less. They have to have a serious or a chronic illness, and they can have life-prolonging therapy. But the similarities are, the commonalities are, both hospice and palliative care are delivered by a team that's more than one discipline, physician, nurse, social worker, chaplain, and both of them address the patient and the family are the unit of care. So never in palliative care do we just look at the patient. While we're doing an assessment, we're asking, and who is your significant? Do you have somebody you live with? Do you have a daughter, a husband? Could we meet them? Can I call them? When we started this, we were pretty much in the hospital. You meet people that are pretty sick, and you tease out on that first interview assessment, who is their significant person, and do you mind if I call them? Because I want to do the same introduction to them that I did for their loved one who's sick. The reason being is, when I say we're another resource, we're another resource. And we can't be another resource if we don't develop a relationship and a rapport. So we go through this with every patient, like, what are their palliative care needs? It's so different for everyone. I mean, some patients will see, and we're seeing this, we started our outpatient program in the cancer center, and we've been there since just January. We've been in the hospital for almost 6 years. And what I'm seeing in the cancer center is those patients, pretty much their predominant need is they have a lot of pain. Does it mean they don't have the medicines at home? They have medicines. They oftentimes don't take them. They have opioids. They'll have, that's what we call like morphine, family of drugs, opioids, narcotics. They have them. They have long-acting. They have short-acting. There's different delivery methods. So I've learned that in my, just in working there, I've learned a lot about what happens when we're not in the hospital with we have a lot of supervision and coaching in the hospital, but when you get out in your home, as you know, if you could teach us a lot of things, it's up to you to manage the medicines, the symptoms, to figure out what, when, how, where. And people get out there and they just forget, and these people are sick. So we look at their medicines, and it's a lot of education, and that's where we begin. That's basic. If we cannot get a patient to be comfortable with either their pain, could be their shortness of breath, it could be they're not eating because they don't have an appetite, so they have more weakness and fatigue. It could be their anxiety keeps them up all night long. I met a gentleman a couple weeks ago. He'd been up for 9 days. He didn't have cancer. He had another serious illness. He was climbing the ceiling, literally climbing the ceiling, with his teenage daughters and his wife, who all said, we can't even stand each other. Every day is a nightmare. That was their pain. So that's where we began. Went back to the pain medication. He wanted medical marijuana. We made that prescription just to get started. And then on subsequent visits, there's so much more that we can cover. But if we don't have the pain and the symptoms well managed, we really can't talk about anything else because people can't even concentrate. Does that make sense so far? Any questions? So that's kind of where we begin. Another thing we do with a lot of our patients, almost all of our patients, is we explore with them, their family, what are their goals? Because when people are sick with a chronic or progressive illness, The way I think of it is, and I try to teach other nurses this and physicians, every time the patient has what we call an exacerbation, does that make sense? Exacerbation, you're back in the hospital, think of an elderly patient, maybe they've got dementia. That's pretty, we can kind of picture that. So they're in the hospital because they fractured, they fell, back out. They're back in with an infection. Every time that they are in with another exacerbation of their illness, their goals might change. So that's something that should be ongoing. We should constantly review what are the goals. When I talk about goals, the way I ask patients that is, what's most important to you? What's the most important thing as you look at the days, weeks, months ahead? We want the plan of care to frame around your goals. So if we have somebody who's seriously ill and the most important thing is to get family, we're like, why are we waiting? What do we need to get the letters? We get the social worker, we bring daughter home from school, bring your mother in. What is most important as we look ahead? Let's make that happen. And really, a lot of times you're giving people permission to do the next step. They know what they want to do, but they need coaching and support to make decisions. So the goals of care we're constantly reviewing with patients. And I say it's not only just the patient, the family. I also say to the family or significant other or loved one, what's most important to you in dealing with your husband with dementia? She may say safety. It may be that I want him to live till December so that we have a wedding. What's most important? And let's try to make that happen. And then the same thing is with the physician. Oftentimes, I'll tell you in the cancer center, when we establish the goals with the physician, I usually start there because it's important that we have to keep that in mind. The physician will say, to maintain the chemotherapy, I want to get him through radiation. I want to keep him on the clinical trial if I can. And then you'll meet the patient who says, I'm kind of tired and I'm kind of done. Our goals now are very, very different. So we have to negotiate a conversation because it's back to the patient's goals, okay? Sometimes the family goals and the patients are east and west. So what do we do then? We do the same thing. So it's lots of active listening. And again, we always tell our patients, you're the captain. It's your ship. So we are advocates for them to be their voice. We try to coach family members as hard as it is. You have your plan, but it is the goals of the loved one that you are showing great respect and value to that person by respecting their values and their goals. It's really about values. And we document, when we talk to patients, families, physicians, it's all documented in the medical record. So that, and as I said, every time a patient is sick, you're reviewing. Your goal may be live as long as possible no matter what, no matter what. In December and 6 months later, it's like, it's not quite so. You know, things have changed. And we know things have changed when people with serious illness, we know signs of decline. And patients and families, they know it better than, I don't have to look at lab work, I don't have to look at CAT scans. When I have people tell me I'm in bed 90% of the time, I'm too weak and tired to get up. I don't want to be out places like this. I don't want to. I'm starting to do this, come in. Only very significant people in my life at this point. And that's a change. Those are signs of decline. And we want to then alter the plan of care to address that. So that's when we talk about goals of care.
Can I ask a question?
Sure.
And this is just sort of, I don't know if you have the, how much involvement you have in the CF world or even COPD, which is as close to CF as possible. Given that our group tends to be on the younger side, and we also may have pretty advanced disease for years. So the question is more about when. When should we all think about this stuff, or, you know, you talked about, well, it's not just at the last 6 months of life, but, and related to our illness, like, there's always that little window of transplantation for some of us, not everyone, and retransplantation, because sometimes things don't go well. And I'm just wondering how, at the palliative care team, kind of integrates with, like, the CF team, the specialty team, as well as the transplant. So there's 3 teams then, and how would that benefit the patient?
That's a great question. Okay, so another big thing we'll do besides goals of care, and that's really a lot of this, although palliative care, we are proponents and we do this with our patients, we're going to see more physicians who are not on our team and nurses who are not on our team doing these same discussions, and that's really kind of the movement as we go forward. But it's what we call advanced care planning. Maybe I'll write that term down, because there's a lot in there that we should all be doing, and it might be where we would start. So I'll write that down. And that's exactly what it sounds like. Planning for the future, advanced care planning. So what kinds of things could I do to plan for the future, no matter where I am in the trajectory of an illness? I can do an advance directive. Has anybody ever heard of an advance directive? Right. An advance directive basically names somebody to be your voice if you were too sick to speak for yourself. Make sense? Do you know what happens if you come to the hospital and you haven't done that? And you were really, really sick and couldn't be your voice? Your family would make the decision. It's not as simple as that. If your family were all in line and there was no conflict and you had a wonderful relationship with the physician, it would probably go that smooth. We see many, and Carol will agree with this, we see many families where there is it just depends. If you've got family members, when I say the table coming to group discussion, and everybody isn't completely aligned, it's not, which oftentimes they're not. The siblings, the parents, the husband, the conflict can be amongst any one of the group, but that everyone pauses in this decision-making process. Because if the patient is the voice, no matter how sick they are, and they have the capability to make decisions, we call that have capacity, they will always be the voice that will trump. But there comes times when people cannot be that voice for the long duration or even for a while when they're in the hospital and very sick. And then you do bring significant family to the table. And sometimes decisions need to be made about next steps, to do it or to not do it. And it's really difficult. When people are not on the same page, things are kind of at a standstill. You spend hours and days trying to help families negotiate. And it's important that you do. Do you know why? Because if the physician just did what they thought and families walked away, they would be so devastated because it wasn't what they wanted. And it's hard enough when you have a loved one that is sick. It's hard to make decisions. It's painful to make decisions. So if it's in conflict with what you believe, your grief after would be so much worse. And all the research shows that. So the more you can bring people together and feel like we've made the best decision, and what we always reinforce with the physicians is families look for recommendations. And when I coach families, I say, your physician, ask what they think. Ask for their recommendation. Because, we went from what we call paternalistic, where years ago, doctors just made the decisions. There was no table. There was no discussion. Then we went to what we call shared decision making, where it's very much shared patient-physician. And it's kind of gone the other extreme, where physicians with legalities and everything are sometimes a little tentative to put their foot out there, so they'll say to the family, they'll give options. And that's really confusing. So it's really helpful, and if you're ever in a situation for yourself or someone else, it's okay to say, this is what I'm thinking, what would you recommend, and help me understand why. Yes.
I have a question. I imagine many of us, or at least I assume many of us, have at least someone in our family that's just not willing to talk about this stuff. You know, as much as I might want to plan, they won't hear it. They won't even think about the fact that I might die someday. Can you help that conversation get started?
We would do that, absolutely. That a lot of the strength of palliative care is difficult communication. And in that situation, we could absolutely, we would meet with you, meet with your family member, and help facilitate it. We have 2 social workers on our team that's really their expertise, and really our physicians as well, because I think that's really important, that what families don't realize, and I've said this to many a family, when the elephant in the room, and you don't allow the discussion, what do you do to the person that can't talk? Where do they do all that stress? We just repress and repress if we're not allowed to share openly. So it's a disservice. So as hard as it is for them, they need to deal with their issues, and you know what I was going to say, I'll finish this point and let me tell you something. Are you a Stanford patient? Because we are now going to go into Boswell Clinic too. We're just starting, so we'll be in the specialty clinics. I just met with someone yesterday. It'll be a rollout, but if you ever ask for palliative care consult, you would have to probably talk about what you would want them to help you with, because your physician's going to say, trust me, we're not there, because they're not there. They don't want to, it's still a lot of bias. But what I tell nurses, if you think a patient or family would benefit, try to identify how. They might benefit from better communication, from planning, making plans, or for better symptom management. When you can pin it down, it's not so threatening, because we still think of palliative care hospice, and it's just much broader. But in advanced care planning, we talk about identifying who's going to be my voice if I can't, putting it in writing, having it notarized, giving it into your medical record with electronic scanned in, it's there for life. Okay? That's one thing. For people that have tough time talking about some of this stuff, I have a great, and I should have brought some today, but I can give a couple to Isa, and then you can probably get these on the website. It's called 5 Wishes, and it's a document it looks like it's 6 or 7 pages. It looks like a lot. But really all it is it's for people that are in really good mental, physical, that you can have these discussions, and younger, because it walks you through, it gives you words to talk with somebody about what you would want if. And it's a great document, and we really are selective about, but you would probably be a great group, would like that. It gives you some control. When you put this in writing and you go through 5 wishes and you say to this person who's going to be your voice, I want you to hear me. And we do work with heart transplant patients as a pilot, where this year we started, the team asked us, when they are doing what they call LVAD, a left ventricular assist device, is kind of a bridge to transplant. If they can get to transplant, these are people with end-stage heart disease, and most of them are middle-aged, they had maybe a bad virus and it hit their heart, and now their heart just doesn't have the ability. And so, but they can't get a transplant. I think it's harder to get a transplant for a heart, so they do this assist device that's like a little battery-operated, but it's inside, and it's pretty invasive. They go to the operating room for it. So they asked us to meet each patient and family and do exactly advanced care planning. So in that context, what we do is that's really all we're focusing on. We talk about, they've already had all this education from their team about what to expect from it's called an LVAD, this ventricular assist device. Ventricular is the heart. So what to expect with this device, there's a whole host of complications. Many, many complications that they might have, and hopefully they won't, but they could. The worst of it being a stroke. And if they have a stroke with this device, their chances are they will not survive. So we will meet with them just one time and again introduce, we're another resource, and we're really here to do a little bit of advanced care planning with you and your family. So we ask them the really important questions. Who would make decisions if you were unable? And if they don't have a written document, which 99% of people do not have written documents, we can still take their word and put it in the record, and it will hold while they're at Stanford Hospital. And then the other question we'll ask is, can you talk a little bit about, I know you've heard about all the complications from your illness, from having your device, and no one wants to talk about this. You know, they really just want to hope it's all going to be perfect, and we all hope it is. But in the event that you had a complication, can you talk a little bit about what you would want? And everyone just says they don't know what to say. So then I frame it a different way. I'll say, if you had an irreversible condition and going to the ICU and being on a breathing machine would not be a bridge to a better outcome, would you still want that? What do people say? No. And I also say, tell me a little bit about, before I go there, I'll say, tell me what you value. Who are you? What is most important to you? And people just like, my independence, getting out of bed, being active in my family activities. Maybe it's my work. So then we say, if you had an irreversible, at what point would you want to say no? And a lot of people say, if I can't be somewhat independent, I don't want to be on a machine. I don't want to be in a hospital. That's not where I want to be.
Judy, I was just wanting to address the situation that we all might find ourselves in, and most of us have good hearts, I think.
Mm-hmm.
But for example, what are the medical choices that we have? Because I actually, when I filled out my advance directive like 10 years ago, I was like, do I want to be intubated or not?
Mm-hmm.
And that's all I thought of.
Mm-hmm.
Yes or no. But there's so many other different choices. I mean,
Well,
How long would you want to be intubated if
Right.
that was at choice?
But CF isn't just the lungs. Like, what if the kidneys go? What if nutritionally you can't go? What if you can't go? You know what I mean?
Yeah.
That too. So all these questions.
Well, if you were on a breathing machine, the reality is, if any of us were on a breathing machine for a substantial period of time, we run the risk of developing other organ failures. So there are statistics, like if you're on it for over 5 to 7 days, if you're on it for 10 days. So the duration on a breathing machine. And I think if your lungs failed, that would be, but the question would be, and I don't know the answer, I'll use COPD for instance. A COPD patient has very debilitated, compromised lungs, right? Over years, chronic progressive disease. Usually they will be intubated, maybe once. They'll come back off of it. They may or may not be back to where they were. I call that baseline. And they may get intubated again. So the question is, if you were sick enough to be intubated, have to go on that machine, will I go back to my baseline status? If you thought you would probably want it. But if I got on the breathing machine and you didn't think it was a bridge, and I had other compromises, this is what I value. So then the decision is made in that context. That's why the advance directive, that yes and no is just not that helpful, because it's all in the context. You know, it isn't just for it's for cancer patients, for cystic fibrosis, for end-stage heart disease. What kind of a bridge is this intervention? That's the question.
I think I filled out a form similar to what you guys have. It was Steve Kaiser, and they sort of made it so it wasn't a yes or no. It was if there was a situation where you needed to be intubated, what do you want to do?
Choices?
Paragraph, you could write your own paragraph.
Mm-hmm. Mm-hmm. That would, and you would put in your paragraph what you would want. You know,
and it could be yes, if this, and no.
That's really where an advance directive is helpful, if you understand your options. So, you could say, based on the recommendations of the team, if I were going to be back to what's most important to you, then I want the intervention. But I don't want it if it means I'm not going to get out of a hospital. People that are on a breathing machine for after so many days, 10, is it about, Carol, 10, 12? You can only be on that breathing machine for so many days, and then what happens is a permanent trach, right? And with a permanent trach, you might be connected to the breathing machine, but that changes your options for life. I mean, can you go back home with it? Some people have to go to facility with it. Your caregiving changes. So every decision-making point, you have to look at how it impacts you in every other way.
The technology changes your viewpoints on your yes and no questions, because 10 years ago, being on a respirator was like, you're done. Now today, a respirator, I know people when I went up to Duke, that's their bridge, is respirator, and they're in the hospital and they're getting physical therapy and they're walking on a treadmill on a trach with the machine breathing for them, but they're keeping them strong, and that's their bridge to transplant.
So
Now,
that's a bridge.
So I would want that, but if they told me, we have to knock you out, I mean, it's so, sometimes those documents are so black and white, and things have changed so, things constantly, new things come out with the medical field, that it's always not a yes and no question.
And that's where you can certainly, if you've identified somebody who you trust to be your spokesperson, having these conversations, I would want it. And I think using that whole thing, if it's a bridge to a good outcome, I'm in, you know. But if it isn't, I may want to think twice about it.
Can you talk about the legal documents that are allowed, like 5 wishes versus your medical power of attorney versus a POA? Or what is, because I have a POA, but I don't have a medical power of attorney, and I haven't done my 5 wishes. So would my POA be able to make all my medical decisions? I guess the document differences.
Well, we call it the DPOA, the durable power of attorney. What many people do is they choose someone, but then they don't have the conversation. So then the power of attorney is in the circumstance where decision-making process, they're making decisions only if you can't. So if they're involved, you're not, but you haven't talked about it, so it's not helpful. Do you know what I mean? And they're still in the same quandary, like what would they want?
Well, and one of the things that my wife and I did with our medical power of attorney, when you do a will, a lot of times they will separate out a lot of the financial stuff and the medical stuff and all that. Is we purposely, when we picked each other as our primary, but our secondary one, we purposely picked people that were a little bit outside of our immediate family circle. Because we didn't want to put that onus on somebody to have to make that decision who was so involved emotionally in it. And, you know, and we picked people that we trusted, you know, their judgment. We knew that they kind of understood enough about our medical situations that they could make a decision like that, but that were outside of the immediate circles, so that it would just be an easier choice for them to look at it rationally and say, you know, this really doesn't look right, and, you know, this doesn't look like it's going to end well, so let's eliminate it.
And that's certainly an option. It's whatever you're comfortable with. Most important thing, whoever you choose, is that they know your wishes.
Yeah,
A lot of people just sign, get it stamped, and then you're back to square one when you haven't had the dialogue.
I'm curious now legally because my dad has my durable power of attorney so that he could help me make the insurance calls when I was just too exhausted. But on my advance directive, I listed my brother to make their medical decisions. Would that be a conflict in an extreme situation?
Are they would they be aligned?
They would be, yeah.
So that, you know, that would be fine, and you can always put, I've listed my brother, but he'll be working with my father.
Yeah, that's what he says. He's consulting the family, but it's his call.
Yeah, and a lot of folks do that, and that's okay. But again, the most important piece is that you've had the tough dialogue. Sometimes we're at meetings, more often than not, people have not. So then you even try to peel the onion. Have you ever talked about it with in reference to a friend or another family member, trying to get some insight into the patient and what they would have wanted? So that's something you can do at any point in the trajectory of your illness. Yes.
I don't know, well, of course it has, because I don't know. So, I have a question about like costs and money, and this might be like nails on a chalkboard, but is there like extra costs associated? Is insurance going to cover this
Palliative
sort of
care?
thing? Yeah, like how accepted in this sort of way is
Okay.
it?
That's a great question. So palliative care, as I said, it's kind of an evolving field. And at Stanford, we started 6 years ago in the hospital, and it was covered. And actually, the hospital pays for our team, and our physicians bill as another consultant, just like you would a cardiologist or an infectious disease. And I think they get reimbursed the same way through the insurance or Medicare, Medi-Cal, whatever. And going in the clinics will be the same thing. Now, when we step outside of Stanford, how available is it? I'll tell you, anybody who's involved with Palo Alto Medical Foundation or Sutter, there's a huge initiative right now to offer it in the community, in the hospitals, but in the community clinics for their patients.
Death panels.
Well, unfortunately, that's been the worst rap for palliative care. We've had to, so it's going to be more available. I don't know where you live. Where, do you live?
I'm in Palo.
Oh, yeah, so Stanford has a program, and we've been predominantly in the hospital, but I'll tell you from an organizational standpoint, they want it available for every single patient that walks in the doors at Stanford that needs it. And they have 18 people think tanks, and I'm amazed. So it's going to be available, and it'll be covered.
Does that mean, like, if you have CF and your lung capacity happens to be 80%, but you feel like you need to talk about these issues, insurance will pay for it?
Yeah.
Regardless of illness status or level?
Regardless, because it would be a referral from your primary team. So as I said, we're the cancer center we started with, we did 30 patients we saw in 11. We're seeing 36 now a month, so just since January 1. And it's referrals from the primary oncologist. And yesterday isn't pulmonary clinic in Boswell? Yeah, so I was in Boswell yesterday just trying to get the lay of the land, because that'll be the next place we go. And there's a lot of behind-the-scenes stuff that we'll have to do to set it up, and that
Seems
can...
like you guys would have to work a lot with your legal department.
Well, no, you don't, not at all, no. It's more the medical record and the billing and a lot of stuff. And then educate the providers. So there's a lot of the pulmonary. Who's your pulmonary doctors? Dr. Mohabir, is he one? Who else? Dr. Dillon. And we've worked with many of... So we've worked with all of them on the hospital side. So today, what I tell patients and families all the time, if you wanted to meet with our team, I didn't even bring cards, but I'm going to give some to you could ask your primary pulmonologist. I went to a talk. I'd really like to talk to a palliative care team, but again, tell them for what reason, because they're going to probably say, you're not there.
So I have a question about, I have all of those documentations you're talking about. I've gone to an attorney, I've had it notarized. But it's like old, and the people I put on there I don't like anymore. Because I'm just an idiot apparently. But my question would be, if I went to my team and I said, I'm interested in palliative care because they want to revise I've also been married since I made that document. I'd like to revise my document. Is that something appropriate to talk to my doctor about? And then I have a second part to that question, which is, then when the let's say he said, okay, and the palliative care, and I'm at Stanford, team comes in, and my biggest issue is just that I really want to start with the legal. Is that something that palliative care provides, or do you provide options?
Well, what we would do is, say you said to your physician, I'd like to talk with somebody from the palliative care team. So possibly you wouldn't need the whole team. You might be able to meet with me or meet with one of our social workers. And we work with the social workers pretty closely on the pulmonary. They're great.
So I could even talk to Meg over there.
Exactly.
I'm interested in revising my legal documents. This is really important to me.
And she may be able to help you do it.
Okay. And
There's
financial. I guess it's really boiling down to financially how it is, because it was like a favor from this friend that I don't talk to anymore. She got her friend to help me do this because she was.
You don't need it.
So now I'm kind of like, I'm stuck financially. How would I do this?
You don't have to have a lawyer do it.
No.
It needs notary, and we have notaries at Stanford. So almost any social worker should be able to bring you, there's the state form, the advanced directive form, there's the 5 wishes, which we have if she doesn't have.
I mean, like, I have a whole, like, bunch
And
of
it's-
stuff that we worked together on, and it was great, but now it's just
Well,
whole.
and
Then
newer
get rid-
documents override older documents.
Right.
So
Right,
if you
right.
made you could just literally shove that aside, create a new set of documents, and those old ones
And that's what I need to
are
do, I mean, I need to
worthless.
just create an all new,
And it's not like this, really, one of the forms, there's like 3 or 4 different forms that all meet the same need, and once they're notarized with a witness, it's legal. And really, to talk to your physician about that, it's really appropriate, and I think we're gonna see in the future a more of an emphasis on that, because what happens when we don't plan, we have patients who are sick getting treatments that it's not what they wanted.
I
And
didn't want these people making my decision.
then you need to,
And like, my mom is one of the people, and I love my mom, that's not a problem, it's just I think she's too close. Now that I'm older, I realize that's not a good.
Well, the end of
choice.
your life is not the time to start assigning duties to people.
Right,
You know what I mean?
exactly.
You want to do that long before the drama of the end of life happens, so that you don't have the additional layer of drama of, the
Right.
decision-making
And
process.
I just don't think some of the people I chose at the time were, now I'm away from it, and it's just not, or they're not appropriate people, and
Right.
yeah, so
there's
that's
better choices now.
Attorneys generally, we went to an attorney about 10 years ago and got all our documents in order. And he just recommends we meet with him every 6 years. We just met with him a couple months ago, and he just sat down and said, okay, have you had changes in family, changes in finances, changes in this, that, this? And he just said, based on your answers, we don't need to make any changes at all. And that was it, and so if you do that with an attorney, not just you, but anybody, if you do that with an attorney, a lot of times they will do it free, just sit down and do a consult to see if you need any updates.
Because
You
it's been
don't-
about 6 years.
You don't really need an attorney, though, 'cause
Right.
you don't need an attorney.
Oh, no, I mean, it was just
These are
a,
just documents now that for everybody to fill out and it's easy and.
the only reason, I mean, I just went to her and she just sort of guided me through
Right.
and helped me.
There are
And like
online
typed up a
sites that
whole
do that,
thing,
too.
I mean, I have a whole thing, the
Right.
documents.
Well,
and-
see, we set up a living trust too, so we did
Okay.
some of that stuff too, but.
Which is more complicated,
Yeah.
yeah, that you need a lawyer for that.
If you go in the hospital, they ask you. to
They
fill
ask
out.
you, I don't, I just say there's one on file, because
Well, the one in the hospital, when
the
you
last thing I
can,
wanna do is deal with that really,
Right.
in a crisis, it's not the time to deal with any even decision-making, even to do this, what do you want, is it a bridge? It's so much better to do it when you're clear and you're thinking down the road. But the one you fill out when you walk into the hospital, who you assign, that's only good for that hospitalization.
No, but they ask you to fill out the orange one. So, yeah.
Advanced directive, is it advanced directive?
Yeah.
Yeah, it's got like an orange cover on it.
Oh, right, that's the real one, yeah, that's right.
You can get the
They
booklet,
have a-
forms free, if you want to fill it out in the hospital, because you need to know, first off, who you want to assign to make your medical decisions in the order that you want.
right,
And
and I
you
did
need-
that
you
in
need
that whole
addresses and
document,
telephone
yeah.
numbers and that
Then
kind of
there's
thing.
sections that you can do. You can think about it, or you can just take the whole book at home. And then when you read the whole thing and you want to add in your own paragraph or sentences, you get it notified. But you can do it in the hospital, and then they either have 2 witnesses or notary, and it'll be the most current.
You have to
But
take
it's
it
only
home and then
about-
bring it the next time.
But it's all about medical decision making.
You can't lose it and forget it.
Well, that's the thing, when I'm at the point of going into the hospital, I'm like,
Right.
nobody else or anything else exists except my frustration and sickness. So, I
Yeah.
mean, like, that's the last thing I wanna do is sit down and fill out a bunch of
Right.
damn paperwork. I mean,
What happens if like the phone number or the address or something that you wrote on one of these documents changed? It doesn't negate the person being.
No, and as long as you put a person, the team works very hard to find that person.
What is a living trust?
A living trust is,
Financial.
it's financial, yeah, you probably,
In the state of California, a person or persons owns, like, say, a house. If you die, then there has to be a legal pathway to transfer that ownership to the other person, or to, like, if both my wife and I died, to our kids, that type of thing. So what they do is you can create a trust that owns the house. And I'm a trustee, my wife's a trustee, her brother's a trustee, my parents are trustees. So any one of these people officially owns the house. And so if anybody within that trustee list dies, the rest of them automatically still own the place. And so there's no legal maneuvering that needs to take place to transfer ownership. And so it makes it really easy when somebody dies. You don't have to go to court and probate and all this stuff to transfer ownership back and forth. It's just it's almost like a corporation that owns your assets, and anybody within that corporation has legal rights to it. And so obviously you have to have trust with the people that are trustees. I mean, we wouldn't, assign it to anybody. But that way, it's so much easier. When Gail's father died, all his stuff was in a was in a living trust with him and one of Gail's sisters.
Mm-hmm.
And so it just made distributing the assets so much easier. We didn't have to go to court. She just wrote checks and distributed out all this stuff, and that was it. And it just it's a way to go.
It's not for medical decision-making, though.
Right,
Yeah.
right.
I just want to check in with people. We have about half an hour left. And Danielle, you have a question, but I just want to, after that question, kind of pause and ask people if, we've talked a lot about advanced care planning, if you have any other questions regarding palliative care and personal experiences or personal concerns that you might have about it. So, Danielle, I didn't mean to cut you off.
Okay. Speaking of that being the last time you want to be filling out paperwork when you're being admitted, there have been situations where I'm admitted in another city than my parents, so nobody who I have signs to be able to do these things around, and it'll be friends that take me in, and I'm just in no position to be filling that stuff out, but they won't even speak to the people that brought me in. Is that something that then the palliative team could come in and do for me, or?
Well, if you were in a hospital outside, and you could certainly ask if they had a palliative care team, and they could be an advocate for you.
Well, I mean, it was my hospital. Like, I lived in Los Angeles, and that was my hospital. My parents live up here.
Mm-hmm.
So nobody was close by as I was getting admitted.
Mm-hmm.
And it's just, it's not easy to do this.
No, so,
In my case, I have a third person on my advance directive, number 3, so that if those people aren't present, that third person can make the decision.
Can it be open-ended, like that third person is whoever I say that?
well, you could when you're going in the hospital, but you probably want your brother and your father, and they would call them. And if you,
Just call them?
they can call them and talk about decision, invite them down, do a conference call. So really, those that you've entrusted to make decisions for you, it doesn't matter where they are, they would be part of.
Well, I mean more just about the filling out of the paperwork, like just the very mechanical stuff.
But if you have it previously on file, say before, if it's your hospital in LA, what we're supposed to do is you retrieve it, print it out, and I would ask someone, is this still current?
Right.
And then they would initial it. And then
Or
we
you
put
can just
that.
have a packet
We put that.
near your door. A packet.
You wouldn't want to do a new one every time.
Right.
No, I don't think I'm getting the question out quite right. I mean, in terms of like signing for the payment of that visit, or when they come to
Them
me with
signing,
Yeah.
them signing on your behalf.
questions about my insurance policy
Yeah,
that they must have answered before I leave, and it's like, I don't know.
I don't know the answer to that.
Okay.
No, palliative care, we're not so involved in those aspects.
No, what I understand what you're asking, Danielle, sorry to kind of tangent. What I do is I keep it in case of emergency letter in my car with all my insurance information, all my emergency contacts. And there's been situations I walked in the yard, I'm like, if I can't sign, I don't sign. And it's not their it's not my friend's responsibilities if they're not on I mean, if they can't sign, then that's the hospital's loss. You know, I give them, I have my friends give them that letter, of the information and say, here.
Right.
Because, if they're not going to be somewhat flexible with the situation, and
Just don't sign.
don't deal with it, yeah. They're pretty nasty when it comes to signing for
Yeah, I think
insurance.
that's my main thing, is that I didn't realize that it's just not.
No. Well, you don't have to sign for payment.
I mean, if you were unconscious, they would still have to.
Right, yeah.
You know.
They're just kind of forceful about it.
They're very
That's what
aggressive.
they say, like, and if you feel like you can't get treatment, you
Yeah.
should sign that form.
But that's not so.
Okay,
I had a lady basically tell my boyfriend at the time that he did not have power of attorney, well, if she does not sign right now, we'll stop treatment. And he goes, I dare you to. He goes, her parents have, it's just, it was,
Yeah, because it's like, I have all that information, my family's on the way usually,
Yeah.
but it's.
Right.
legally they can't, so you don't have to sign.
I think, you know how we're all, in the hospital situation, we have so many regulations, and I think there's something about the admitting department, and it's probably tied in with billing and patient rights, now that they have to try their hardest to get a patient to sign the consent to be admitted to the hospital.
That's the biggest
That
thing.
multiple page thing is telling you that you agree to be treated in this hospital, blah, 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 that if it's a teaching hospital, there might be, if you read all the fine print, that's what it's saying, and you sign that you agree to be admitted and treated, and that's what they're trying to go after. And I don't know if that's been required by it's something that probably insurance companies would like to have on record, that you weren't brought in against your will. But, so they will try to go after anyone that's alert and oriented to make them sign.
Yeah,
You should
hear
see
that
if
later.
you're on
Somebody should
Medicare,
play possum.
on Medicare, there's even more paperwork that they try to get them to sign. So, because there's rules, like the Medicare, there's rules that the patient has to sign so many papers, even on discharge from Medicare.
Yeah,
Trying
and
to
my
get
Kaiser's
these
big
patients to
push right
sign.
now is like, well, we're moving away from billing, we can't bill you, you have to pay now. Like, just, I don't have it in the bank, I don't know
What?
what to tell you. But yeah, that's been the response for years now.
But yeah. You don't have to if you don't feel up to.
No, you don't.
You guys, if I
Feel
put some,
sorry.
I forgot to mention this, there's these little pieces of paper. Everyone's so great about opening up and asking questions, but if you have anything that's kind of bugging you or on the tip of your tongue, you don't quite feel comfortable asking it, you can write on a sheet of paper and let's see, I gotta find a strategy. It's not so obvious, right? You don't have a box, you put it in
Well,
the middle of the.
you just stand up and read.
Exactly. We didn't have a good system for this, collecting the sheets of paper.
Actually, going back to palliative care real quick, would you recommend for somebody, a parent, a family, who has a chronic ill child, that can start palliative care as early as possible, so it continues through their illness?
Well, I mean, I think at Lucille Packard, they have a program for children that are seriously ill.
And I'm not saying they're gonna die when they're 10 or 20,
No.
you may make it, like CF, where you're living in your 30s, 40s, 50s, but just a good, easy path.
Well, and the focus is quality of life and symptom management and enhanced communication, so it is a good idea, and I'm sure that at Lucille Packard, they do that for kids that have, because the other thing is you never know, at different junctures, you may have more physical, social, emotional stress,
Mhm.
and they could help facilitate, care. So,
Is that something that you can do, like, your clinic sees a patient just once a year or whatever to check in and make sure they're on path with the goals that you set together, or
Mhm.
have any questions about communicating,
mhm.
I mean, can you do that kind of long-term care?
Well, palliative care is long-term as long as the patient needs the care, and hospice is end-of-life care. So when we see a patient that is in the last months of life and no longer getting a life-prolonging therapies, then we will usually suggest a hospice. But until that point, our team will follow as often as needed. And with some patients, it's going to be we're seeing them every week because things are changing quickly. And other patients, it will be a one-time, like our cardiac patients, just to have this conversation. And then when patients do what we say meet hospice criteria, which is very they have to be in the last months of life. They have to have no more life-prolonging therapies like chemotherapy or radiation or certain medicines that they get intravenous. Then we transition to hospice, because with hospice service, they're going to get more hours of care. They're going to get an attendant that'll come to the home and give them a bath. The nurse will do visits 2 or 3 times a week and call the primary team to give updates. A patient that has a lot of symptoms, not a lot of social support, this is a team that goes to them. That's also social worker, nurse, physician. So until that time, palliative care is available. But we'll transition to hospice when more services are needed.
I was really, really lucky to have a pulmonary specialist as a kid that was at least aware of all of this stuff.
Mhm.
We didn't have a team to support it, but he encouraged us to go find that support in the different areas. Do you see this as eventually being a part of medical school? It's required for physicians to at least understand?
Well, there's a lot of training going on right now with the residents, like at Stanford, once a month, they have a lecture every day. Once a month, the lecture is palliative care. And I'll tell you, this is our 6th year, and July started the new service, and every week we have 1 or 2 with us. They are choosing to spend a week or 2 with the palliative care team, which last year we had probably 2 weeks out of 52 weeks. And this year, we've had 1 or 2 every week in July. And it looks like we're going to have them almost every week. So this is, we're just beginning, you know, but they're understanding this is a big part of, everybody who practices nurse physician, we're all doing palliative care, right? We all should be looking holistically and maximally managing symptoms and talking about goals. Every time the patient is sick, what's most important to you, to your loved one? How can we facilitate a plan of care that addresses your needs? Recognizing that with a chronic illness, things change. It's not stagnant. So yes.
I wish the physicians would just learn pain management. That'd be a giant step forward.
That would be.
There alone.
How much of your palliative care is pain management?
Actually, more of it is goals of care. But we do, even when I track all of our data of why we're called in, who calls us in, which teams, which doctors, which units, what clinics, and most of our requests are for goals of care, because there's that fork in the road, and the physicians are like, not sure, here's the options, I don't know what they want. They're having struggle with the communication. But no matter when you get in, we always assess pain and that, and there's a lot of folks that they have pain besides. So it's an opportunity. I say the patients that are sick, there's always an opportunity. There's always things that they need, so. But not predominantly pain, but we have a pain service at Stanford. So, and very active. If hospitals that don't have a pain service, palliative care becomes the pain service. So that, you know, you're absolutely right. But we're fortunate. We get to do way more than that. Other questions?
Oftentimes, chronic illness or grave illness, people who are chronically ill, gravely ill, are also in poverty. In this palliative care framework, is there ways to address issues of poverty, such as housing, food, transportation?
We have social workers, so our social worker would help identify resources. And it's covered by insurance, it's covered by Medi-Cal. And as I said, like Kaiser now, it's a huge initiative at Kaiser, it's a huge initiative at Sutter. And the next step will be, not tomorrow, but over years, where you'll have palliative care clinics. I mean, really, there's so many people with chronic illness. And if we addressed the needs out in the community, we'd prevent a lot of hospitalizations. And what happens, unfortunately, is when we don't address the needs as we go along, there becomes a crisis. And what happens in a crisis, we're back in the hospital, and once we get in the hospital system, it takes a life on of its own, regardless of what you wanted or thought was important. The technology, the critical care unit, we move in that direction, then we stop and say, well, what do you really want? What should we do? But generally, we're pretty far down the road before. And so there's, people all over the country now are saying, is that the best way to go? So, but where if we do along the road, we constantly reestablish, document, talk about it, we're clear about our goals, we're managing the symptoms the best that we can, there's less likely those crises will get in that circumstance. I mean, I just had an article that was, in my desk this morning, it keeps coming up, that they do surveys and studies, and most people, when surveyed, they don't want to die in a hospital, they don't want to die in an ICU, they want to die at home. But 70% of people in our country die either in an acute care hospital or a skilled nursing facility. Because what happens, you get down that road, and so you have to have.
I was just reading a paper, sorry to interrupt, that 91% of CF patients die in a hospital. That's a lot.
That's a lot. And if you're ever in the hospital with one of these serious illness, and you can get your goals established and have a team that's listening to you, when we meet patients that are really, really sick and we say what's most important in the days or week ahead, and we know prognosis is poor, they don't have a chance of living a long time, we will say, if you really want to get home, we can almost always make it happen. And that's almost like within 12 hours. We can get hospice in, hire a caregiver if you need to, get the equipment in the house. All of that is not that difficult. It's making the decision and making sure people have caregivers.
I think the hard thing with CF continues to be like this idea of, what about transplant? That people are waiting and waiting and waiting, and then they're on the vent, and they're waiting, and then they're waiting, and then their kidneys fail, and then palliative care is very complicated because you're preparing to die, but also preparing for the call.
Well, you can't simultaneously prepare for both. I mean,
Well, sometimes we'll say to our patients, we will try to prepare for, say we would prepare for transplant, but put Plan B in place just in case. And we have to do that, right?
But the real problem is that you don't live up until you die on the list. So you don't get to have that. You don't get to have that hospice care if you're really going for it.
You stay on the ventilator and.
Well, you stay on the vent, and then if you're on the vent past the time, then they'll let you go usually. I mean, it's kind of that. It's very tough in the CF world if you are going for transplant, because if you get to that point where you're at the end, they do every measure to keep you alive until they can't anymore.
So I guess the question is, how can palliative care be hopeful? Like transplant is the hopeful path at the end, but if this is another choice, how can we present it as hopeful for the family?
We might hope for different things. If we didn't get the transplant, we hope that we can make a patient very comfortable. We hope that they can still pass with dignity surrounded by their loved ones. So we just hope for different things. There's always things that we can hope for, but it may not be what you wanted to begin with. Because if we have to stop a ventilator because we knew there was no transplant, we still want to make sure the right people are at the bedside and all the medications are in place to take away breathing distress and anxiety and pain. And those are really important things, and we don't just assume they would be there. That we meet your spiritual needs. I mean, this is for patients CF or other, do you have a faith community? Can we get someone in? And what we find is we would never stop a breathing machine on anyone, even if they couldn't get the transplant or they had 4 organs failing and we knew that the ventilator wasn't, where was I going? That the ventilator would eventually be withdrawn. That is pause to say, what's most important now? Always. We have to get a family member there. We have to bring a Buddhist priest in. We have to bring a child in, and a dog in. What is this patient? What's most important? And sometimes even bringing children in. It can take hours. More than 24. The family has to be prepared before they can help prepare the children. Then you'll have a whole team there to be with the child. social worker who has expertise with children, and maybe one of our physicians or one of our nurses, and then work the child through it. So there's always time to do those important things. And if possible, like you said, sometimes you can't get home when you get to that point. But sometimes when ventilators are withdrawn, we don't always know that people will pass right away. And then we move to a comfort scenario in our hospital, and if a patient survives, then help transition them home within hours, if that's
How
important.
do we really know if like these meds like prevent you from feeling that shortness of breath?
Because the medications are very, very effective. When people are short of breath, the most effective medication is that family, I'll put the word here, it's opioids. We don't like to use the word narcotic in the hospital, because narcotic has a connotation of what? Drug dependency.
I think if you're giving end-of-life care, it's probably not too big of an issue.
It isn't, but it's,
People worry about it.
people still worry about it. So when you use the word narcotic, it just has that connotation. So it's really opioids, and opioids, what I say to patients, it's like morphine, or it might be Dilaudid.
Do you mean in the sense that like the patient won't really then tell us, right?
Yeah, there's no way to know.
Well,
Qualitative experience of
Right.
that moment or that point.
Right.
well, we see patients when we use opioids appropriately, and like I said, these are three of, and there's others, they're all in the same families, they're different delivery, but when we use them appropriately, we will see that shortness of breath, totally, the labored breathing of using all the
Your
extra
body
muscles,
relaxes.
it totally relaxes. And if there was a patient in such extreme shortness of breath that this did not work, you could also use relaxation medicines like Ativan or Versed, and you can put them on a continuous infusion. And that would be a patient that maybe, but actually, they use them at home with hospice now, Versed drips, which I was pretty surprised. So you have categories of drugs. These drugs are really to take away that feeling of breathlessness. People are afraid.
Don't you also fall asleep?
People are afraid that when we start
Of course you
these,
wouldn't feel breathless.
the people are afraid, and family members are afraid that whenever we start an opioid, that we're doing what?
Hastening, hastening.
Hastening.
Right, right.
Everybody thinks that. So I have learned in my travels that when we talk about using opioids for shortness of breath or even for bad pain, I say, this will not hasten the dying process. It will not hasten the dying process. Patients will die when it is their natural time, but it will take away the labored breathing. It will take away the pain. Sometimes people go to sleep, and guess why? They've been up for hours.
Tired.
Hours, days, and then you give them a little baby dose. And then you start giving them a little tiny drip. I had a physician come up, I did what you said, and the patient's been asleep for 4 hours. I go, please don't stop it. This patient was in extreme distress. Please. Slept another few hours, but the next morning sitting up having breakfast. The body adjusts to these medicines really quickly. But when they are exhausted from the work of breathing, or from pain, or from anxiety, you give them something and their body goes to sleep. But it never means that they will not wake up. Never, ever.
That's the push anyway, isn't it?
The pushes,
Morphine push, that's how you get them.
how you get them.
That's how they're not gonna wake up.
No. It's deliberate. No, that's totally wrong. That's totally not true. I say different delivery methods. It could be IV push. It could be under the tongue. It could be a patch. All delivering the same medicines. In the hospital, we do use IV push. You know why? Because it's really quick. But it's got a really short life.
No, I'm not talking about the comforts to make them sleep.
So you're talking to hasten. You're talking. So if somebody wanted to hasten, you are saying that that's how you would do it? Okay, so families ask me about that quite a bit, and I always start out by saying, none of us in the hospital are about that ever. And if you wanted to do that, it still would be hard. The body adjusts so quickly.
But
So it won't happen. I mean,
I think I know what you're asking. How do you know if someone's already not conscious and they look like they're in distress and they start working, is it really helping their distress or pain? So I've had a couple of patients in my years of work. Someone with COPD, totally panicked, afraid to go to sleep because they think that they will die, but they can't breathe, and they're so anxious, and they've probably been up 3 days, okay, just dozing for 5 minutes, and we're just like, and then, of course, the decision was made, they're not going to ICU. So we're dealing with them, and finally, and the doctors, and what you say, your comment, I think maybe 80% of the population and the doctors, no one wants to start the morphine because they think that will hasten death. But we gave morphine for breathing for this very anxious patient, and all of a sudden the patient felt better and calmed down and slowed down the breathing and did not fall asleep, but felt better. And we were able to give it in doses, and it really helped.
I guess what I'm thinking.
I know that, and some patients, yeah, it will put them to sleep, and it might.
and they may be their end of life. Yeah.
But then others, it does help. So, I mean, everyone's afraid, even caregivers, even doctors. I mean, but you have to think about, and the patient might be afraid, but are they suffering? You know, maybe they should try, and you could try at the very lowest minimal dose, and if it doesn't work, if they don't like, it makes them foggy, or they don't want to sleep, they could try other medications. But if all you're doing is focusing on every breath, and you're breathing 50 breaths a minute,
Yeah,
I don't think the patient's comfortable.
I have pain after surgery and made me think about it, and I can say that it does relax you, help you breathe more comfortable. I mean, so if you're talking about low doses, for example.
I
But
think
I think what you guys are thinking about is like the Jack Kevorkian type, mega doses to snow them into death. And I don't think that's
You might
really.
also be mixing up opioids and barbiturates.
Yeah.
that's
And barbiturates are the ones that would be used to
right.
slow down those processes.
Right.
With opioids, I think it would be kind of hard because
Because they're more effective pain receptors.
right, and the breathing.
We've both been on all of those before, so I think we know acutely how they work, but I'm interested to hear more about what you mean.
No, I just think that if you have lung failure, that when my experience was being on morphine suppressed my breathing, so I just gradually faded. And because I wasn't breathing, because my lungs were failing, the CO2 went up. And that would be my natural end, right? And so in extreme cases, it would seem like you're taking away the pain, but the falling asleep is really the natural dying process. That's what you were saying, yeah.
And
But-
what you're saying is if you do retain a high level of carbon dioxide, CO2, that will stop you from breathing too.
Ultimately.
But nowadays, we do morphine drip and BiPAP, which is non-invasive. And so that will take out your excess of carbon dioxide. So there's more intervention. It really depends on what the situation is and what the patient wants, what the team is thinking. But I think there's still that fear of morphine or giving too much medication, even though we might want to help the pain and discomfort. People are always afraid, is that going to help them die quicker? We don't want that yet.
And they usually start with such low doses that we just, with our eyes, we can see patients breathing more comfortably. The rate slows down. They're not using all the extra muscles. And sometimes use a combination with something for relaxation as well.
When my grandmother passed away, she broke her hip, went in for hip surgery, and then they gave her the lowest dose of morphine, and she was just ready to leave. She just wanted to leave. And it was a big, kind of a little bit of a controversy in the hospital why she was dying when, you know, she just had surgery and they gave her this little bit of morphine and they kept saying this can't be killing her, you know, because it's too small of a dose. And she just said she used that to relax and then leave. And it was just her time to go.
Oh, she passed.
Yeah, she left, yeah. And she didn't want to stay anymore. And so she used, what?
It was like a bridge.
Yeah, and she just used that opportunity to relax enough to leave, because she was in my place, but,
And that was probably her natural end-of-life phase. I mean, really, it's not the morphine, I
No,
mean,
and
it's
that's
just,
what the doctors kept saying is, you
Would've.
know, this is too, it was the smallest dose, and it just relaxed her enough that it was just her time, you know? So, I think that can happen, and maybe that's interpreted the wrong way.
Well, the father of opioids is antioids and opioids.
So it's 3:30, out of respect for this camera staring at you, Judy. I just want to, before we completely finish, like, does anybody have any last-minute comments or questions for Judy?
I think this just sounds like a really needed and a good thing to have available. It just sounds like a wonderful resource.
I'm glad to know there's not really a correlation between hospice
Yeah,
and palliative,
yeah.
because I really didn't know that, or would
Yeah.
never have sought
Most
out
people don't.
that help. Right, it just seems to me it's more like it's like an extension of, say, having a social worker. This is like even branched out further than that. Which is nice to know that resource is there.
it's out there, yeah.
Well, let's give Judy a
Yeah, thank you very much. Thank you. You were a great audience,
Thank you so
and
much for coming, taking time out of your workday to join us.
thank you for all your questions and comments. I really appreciate them and have a lot of respect for your journey. That's helpful.
Thank you.
You're welcome.
I don't need much either.
Thank you for caring.